Well, hello and welcome back to Anesthesia Alchemy, Lynn and Garry Unplugged, where we dive deep into the most current and clinically relevant anesthesia topics just for you, the practicing nurse anesthetist. As you all know, I'm Garry, and it feels great to be back into the studio after a short break. As many of you know, we've been in a bit of a hiatus the past 3 months due to some structural and administrative changes behind the scene as we improve our podcasts. But it is 2026 now, and we're kicking off a brand new year with fresh energy, new voices, and as always, solid clinical insights that you can use every day in the OR. Now, today, while my partner in clinical crime, Lynn, isn't joining us, due to some scheduling conflicts, and don't worry, she'll be back in the next episode very soon. In the meantime, I'm excited to be joined by none other than Richard Wilson. Today's episode is all about goal-directed fluid therapy, or GDFT, which Richard Wilson is an expert at. It's a topic that's as important as it is controversial, certainly. And whether you're a firm believer or still sitting on the fence about goal-directed fluid therapy, we're going to break it down, challenge a few of those assumptions that you may have, and explore what the latest evidence has to say and potentially influence your practice moving forward. So plug in, scrub in, and let's get into it.
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to the Beyond the Mask podcast. This is the Anesthesia Alchemy edition. Join hosts Gary Bridges and Lynn Maxey as they deep dive into today's most important clinical conversations.
Okay, well, before we get started, Richard, why don't you tell us a little bit about yourself and your practice and how you actually became interested in goal-directed fluid therapy?
Yeah, Gary, thanks for having me. So I've been practicing anesthesia since around '06. That's when I graduated. And then shortly afterwards, I joined into education about '09, opening up a satellite campus for a program in South Carolina. And then recently, about a year and a half or so ago, I moved over to another program, the Somnia Nurse Anesthesia program with Ursuline College. And so I've been in education really for almost about 20 years now, about 19 and a half, 20 years. So loved it, enjoyed it. And then obviously through education, I have been teaching in many, many different topics and really start looking at goal-directed fluid therapy. I can remember when, honestly, this concept came out. What was it, probably 12, 15 years ago, as it started kind of getting a little bit in its infancy and then growing from there. So I really enjoyed that. And then I do a lot of orthopedic trauma cases. I do some neurosurgery cases in my clinical practice. All of that kind of fed into why does fluid management matter?
Right. It's certainly a really important topic and not without controversy, which we'll kind of get into some of that today. So, well, let's go ahead and just kick it right off. Why don't we sort of define really what is goal-directed fluid therapy and how does that apply to a nurse anesthetist clinical practice?
Yeah, so when we really think about goal-directed fluid therapy, I mean, it's got a lot of it right there within the name itself, right? As we start looking at what are our goals with this fluid therapy, as we start thinking about, okay, we're not just giving fluid. There's got to be a purpose and a reason behind why we're giving this fluid, whether it's the amount we're giving, the constitution of what we're giving, the type of fluid we're giving. All of this really matters. And really when we start thinking about why does it matter, is because we really see all of the things increase that need to increase, right? We see better vital signs, better perfusion of the organs. We see better management of our patients and getting them in and out of the hospital, especially for those that are having to stay in. So we're seeing decreased length of stay, decreased infection rates. And so really when we start thinking about goal-directed fluid therapy, we're really taking our patient and taking care of them as an individual, not as just a group, right? We're not looking at it like we used to. And I know you've probably been in practice for a little while yourself. And hey, let's just throw a bunch of fluid in here. Let's just give them something. Let's see how this works out. We really now are looking at, okay, the amount of fluid we give matters. And the reason it matters is because it's going to affect a lot of that stuff we just talked about that I just mentioned and more.
Yeah. So, goal-directed fluid therapy, or GDFT, sort of a newer terminology in the realm of fluid management. Let's kind of roll back a little bit as far as history goes and kind of talk a little bit about the historical evolution. And I think we'll get into some of the Frank Starling stuff. And I think what's really interesting is, and you've brought it up already, a little bit of, fluid, what kind of fluid, how much fluid. But I think looking at the historical perspectives to really appreciate where this debate, controversy, and why we've really had to set up a structure comes from. So maybe kind of bring us back a little bit with some historical context, if you will.
Oh, absolutely. So, I mean, if we go back and we look, and it's even taught in some of the textbooks today, especially its historical perspective, we teach in our program its historical perspective is really the 4-2-1 rule, right? Where you start thinking about, okay, for the first 10 kgs, we're giving 4 cc's per kg, and then it kind of varies from there, right? Afterwards, looking at the 4-2-1 rule. Then we start looking at the estimated blood loss and how we're replacing estimated blood loss in a 3-to-1 ratio versus a 1-to-1 ratio, if we're talking about replacing it with crystalloids versus colloids. Then we start looking at the NPO status. And now remember, this is before we started looking at the impact and the benefit of letting them have carbohydrate drinks or being NPO, except fluids for 2 hours prior to surgery. We had people that were 10 hours, 12 hours prior to surgery having nothing by mouth. And so we were going with the NPO status based on their kg body weight, based on their, their maintenance fluid rates. Then we started throwing in there what, we all know is the third spacing, which there's a lot of controversy on that now. But we started throwing in there the third spacing. And so we really started looking at it over time. That is a lot of fluid. I mean, I use that in a calculation with my students in one of our courses. And, we're giving over a couple of hours, we're giving 5 liters of fluids if you're using that system within itself. So I can't remember exactly what year it came out, but I believe it was in the Chest Journal, where it started really looking at research that said, hey, we are overloading our patients, and we're starting to see results that are not good, right? We're starting to see that our patients are having fluid overload. And we know, as you talk about some of this, I mean, some of our patients, especially in our level 1 trauma centers and our cardiac patients, they're sitting on that curve of going into congestive heart failure just from a little bit of additional fluid. So we started really looking at, and the journals started looking at, okay, how do we maximize or optimize this? How do we give just the right amount of fluid so that, as you mentioned, the Frank Starling curve, right? And you start looking at the fact that, you start stretching that ventricle out, you're going to get a better contraction. We know that. You get a better contraction, you get a better EF out of it. However, there's a point where when those sarcomeres stretch enough, you're done.
That's right.
You start to get that negative impact, right? You start to get a decrease in contractility, therefore a decrease in cardiac output. And when they started bringing all of this together and then looking at the importance of perfusion pressures, as we talk about, the kidneys taking a hit or any of the other organ systems, it became pretty vital, and it became pretty important that, hey, we need to really look at the fact that if we do goal-directed fluid therapy, instead of some of this historical perspective of just throwing a bunch of fluid at them because that's what the numbers say to do, that we're really going to get better patient outcomes.
Yeah, you know what? Sort of when I think back to clinical practice and just even over the last 30 years, 30 years ago, to your point, flooding everybody with, they need a leader because they've been NPO, or they need another leader because they're hypertensive, and, these types of things, and not really appreciating the damage that we've actually done, which, contributes to surgical site infections, wound dehiscence, and, the laundry list goes on and on, not to mention sort of compromising their physiologic capabilities, if you will. What's really interesting, and I'll take it even back a little bit we'll get into Frank Starling's law and stuff. That paper, which was a pivotal paper that was written in the 1800s, and that is what we base a lot of the stuff off of today, which is just fascinating. And really, up until probably the last decade and a half, haven't really moved the needle on it. And now we're actually literally focusing on it. So let's jump into Frank Starling's law of, heart and sort of what those variables are, so that we can give a little bit of a review, and for those that are a little bit rusty on it, get you back up to speed.
Yeah. So obviously when we start talking about, pumping blood out from the heart, right? Because the biggest thing is we're trying to get all this blood out. What we're trying to do is we're distributing this fluid all throughout the body or getting it pumped out all throughout the body so that it can have multiple purposes, right? When we start looking at the fluid and we start looking at blood pumping through the heart, through the vasculature, and then back up into the heart itself, we're pumping it out so it can get oxygenated, go through the lungs and get oxygenated, right? Going from the right side through the lungs, get oxygenated, come back to the left side, and then it's going to get pumped out to the rest of the body. And the purpose behind that is really multifactorial, right? As we start looking at one, perfusion of the organ systems, and we want to make sure we've got good perfusion. We've got to have delivery of oxygen to the cells. Delivery of oxygen to the cells is going to help them stay alive. It's going to help them function like they should. But not only that, is it's picking up that byproduct, that carbon dioxide, which is the byproduct metabolism at the tissue level, to bring it back up so that it can actually be excreted, because we know that's got problems there in itself. Then we've got to worry about the fact that also what we're pumping out in this blood has electrolytes in it, right? We've got the sodium, the potassium, we've got the calcium, we've got all of this that plays vital roles in the organ system and within our body and the way it functions, not just in the heart and the lungs, but you got to look at the endocrine system. You got to look at everything, right?
Yeah.
That's why all of this matters. And so when we start looking at that, it's all about cardiac output. And the way we figure out cardiac output, right, is heart rate times stroke volume.
Right.
And one thing that we can look at is the fact that with fluid therapy, can we change? Let's get back to this and let's look at cardiac output times heart rate. Can we change the heart rate? Absolutely. Mm-hmm. We would all be sitting here lying to ourselves, right, Gary, if we say that we haven't changed the heart rate when they started gating a patient during lithotripsy so that we can get out of there quicker. You're right. I mean, we've all done that at some point in time. We've all getting a little bit of Robenol to change that.
Right.
But does that necessarily have an impact on the cardiac output? Maybe or maybe not, because now that your heart's beating faster, does it have enough time to fill completely? Right. So how do we get all of that to really balance out, right? We try to make this simplistic, but with all the technology and all the knowledge that's coming out now and all the the literature, we're able to see more about this. So now let's figure out how we're going to affect that stroke volume. Well, that stroke volume has to go with the fluid, but it also has to go with contractility when we start looking at that, right? And it also goes with looking at systemic vascular resistance. But let's really look at the fact of the stroke volume in itself. When you look at the fluid side of this and Frank Starling law, if we don't have enough fluid in there, our cardiac output's going to be terrible. Right. It's going to be decreased because it's going to be in the fact that, hey, one, you don't have enough volume actually to get the volume out. You don't have a large amount of volume to have a good stroke volume in itself, but then you're not stretching those muscles enough in the heart. You're not stretching those sarcomeres enough in the heart to actually give a good snap, a good contractility to it. And again, we got to be careful though. And this is where the goal-directed fluid therapy comes in, because yes, we did it. We gave fluid, right? If they're hypotensive, give more fluid. If they're still hypotensive, give more fluid. Right. But what we started finding out was, hey, now we've got to think about the fact that it's not just fluid causing the hypotension. There's vascular resistance. And if we got a severe decreased vascular resistance, it doesn't matter how much fluid we're giving them. And we know our inhalational agents cause decreases in systemic vascular resistance. Right. Doesn't matter how much fluid we give them. It may actually hurt the heart, but not help the blood pressure within itself. Right. So that's where the Frank Starling law started coming into effect, that, hey, we could be stretching things out so much, giving them so much fluid, trying to compensate that we actually send them into potentially congestive heart failure.
Yeah. So, that brings up a few things. Like when you talk about contractility and setting that preload, where I almost think of it like an elastic rubber band. I mean, you can stretch it to a certain point to where you get, and you're trying to optimize that obviously with the fluid resuscitation, if you will. And as you've mentioned, you get that snap, so you get that rapid ejection out of the left ventricle, ideally. But if you got that pipeline that it's pushing against the aorta, for example, if it's too narrow or too wide, you're not going to. So you got to balance all these little parameters, and that kind of brings up a little. I use the non-invasive hemodynamic stuff all the time in a lot of the cases that I do, and one of the things. It's case dependent or case type dependent. For example, I do a lot of colorectal surgery, I do a lot of pelvic exenerations. And one of the things that I see in that patient population, because of the manipulation of the bowel, is that their stroke volume or their SVR, systemic vascular resistance, like tanks. And it's not uncommon to see an SVR that will actually drift down to 400s. And it's not enough. It almost sets up a picture like sepsis, right? Where you get high cardiac output, low SVR, and you're like, yeah, you can give some volume, but you still have to tighten them up to make sure that you balance all of these parameters. And so there are some nuances, not only from the physiology standpoint, but sort of the case type that we're doing, as well as the patient selection that we're dealing with, right? So you have, a cardiac cripple or somebody with metabolic syndrome is going to be very different than our marathon runner, for example. So really, really interesting and important factors that, I think our listeners need to really understand. So with that being said, and I've kind of alluded to some of it to kind of set up the next thing, so what are some of those monitoring technologies that are out there? And God, there's so many of them now. And there's new stuff. That I was using a device 2 weeks ago. It's not on the market yet. They're doing all the research, the clinical research. I think there's like 12 centers that are on. And it's basically a non-invasive cardiac monitor. It's looking at blood pressure right now, but it gets all that waveform analysis by putting this device on a patient's foot, and it looks at the pedal pulses and it starts calculating SVR. It's a beautiful looking device, but we're going to find out if it's useful or not here because we're comparing it against our other non-invasive monitors. But let's get into some of that technology and, what we're really looking at to try to determine how do you optimize and make a decision. Do I give more fluid or do I look at a different alternative to fluid?
Yeah, those are all great questions. And really, when you start looking at it, one of the key factors to really understand here when you talk about it, Gary, is there are too many monitors out there to really even have a discussion about today, right?
Totally agree.
And so it's really important that when you go to these conferences and they're doing new monitoring systems, get to know them, go take a listen to them, right? Because you need to know what's being utilized in your system or be familiar with what's out there. And then when something comes into your system, you need to know that inside and out when you start looking at utilizing it, because they do have a little bit of variations, right? But what I really like about them, and there's some out there, there's new Swan catheters out there that have the technology associated with it. You've got the BD catheters, you've got all of these things that have the association. And you know where they all came from, which is pretty interesting? AI technology.
Yeah.
When you really start thinking about this, the AI technology has advanced these systems so rapidly that we're now seeing where, you've been practicing a number of years. I've been out for 20 years. We might see one of these monitors come around, every 5 years, every 8 years, maybe something might come out. Now we're seeing something come out every year. That's got some kind of technology associated with it. And what I love is these things don't give you just one parameter. So you can't just look at it and go, okay, well, it's telling me that my cardiac output is 2, and therefore I need to have something that is an inotrope, right? No, it's telling you all kind of factors. It's telling you what your cardiac output is. It's telling you what your stroke volume variance is. It's telling you your end diastolic volume compared to your end systolic volume. I mean, it's telling you so many different factors. But the importance to know is, do you know what those factors mean? Do you know what those numbers mean? And unfortunately, I've had a lot of conversations with people over the years and speaking at meetings and start talking about this. And I'm like, hey, have you seen this? And have you seen that? I'm like, they're like, no, I didn't know what that number meant. I saw it on my monitor, but I didn't know what it meant. I'm like, come on, you got to know that. Right. And so really what I'm looking at is what variables have to be with these monitors. Let's take stroke volume variance monitors for just an example, right? Love those monitors. I think they have great utility when you start looking at them. They're going to give you the cardiac output / cardiac index. They're going to give you your stroke volume variance, where it's comparing the end systolic volume to the end diastolic volume. And when you look at that, for example, if you've got over 15% change in that, then your patient's dry and you want to give more volume. However, if you've got less than that, then it's saying, hey, you don't need to keep fluid loaded in them. Your problem now is your SVR, so you need something to tighten them down. Maybe you need to use phenylephrine, norepinephrine, vasopressin, something along those lines to tighten them down. So it's helping us be really, really much more specific, because you know as well as I do. Again, let's take one of those cardiac cripple patients that you mentioned a little bit earlier. We keep loading them. That's a problem. However, if they don't have enough fluid on board, if they don't have enough preload, And we're not paying attention to that. We're going, oh, we just need to increase their MAP. Let's give them phenylephrine.
Right.
Now we're taking that heart and we're making it go against the even higher SVR, which is putting additional strain on the heart.
Right.
So this is why it's becoming really important that we optimize. Do we need to give fluid? Do we need to give pressor? Do we need to give an inotrope? And these monitors are helping us do all of that when we look at how we measure these patients' blood pressure, cardiac output, cardiac index, when we look at pulsatility on these monitors, so many different variables.
Yeah, and that brings up another point, and I think one of the great ones is stroke volume variation, and I think one of the caveats with SVV is making sure that a couple of things, looking at the trend, number one, especially when I have students in the OR, they want to treat it right away, and I'm like, well, okay, first of all, why are we watching this stroke volume variation? Is it just a blip on the screen? Or is there a trend that it's actually moving in a direction that would warrant fluid resuscitation? And one of the things that I tell students, and it's probably a reminder to some of our colleagues out there, is stand up and look over the drape and know what's going on the surgical field, right? I will say that I don't watch the stroke volume variation number as much as I do at waveform analysis on my arterial tracing in big belly cases, or liver cases or pancreatic cases, because they're constantly pulling on the SMA, the vena cava, they're putting, hepatic inflow is changing, renal art, and that all has a consequence. And so it's a judgment call based on what's going on in the surgical field, and optimizing your numbers to see, all right, does this make sense? Looking at the trends. And then, we'll get into some of this. Once you give that fluid, let's say bolus, is there a change or is there not? And if there's a change, that's great. They're responsive. But if they're not responsive, do you need to give more fluid? Or do you have to, and we've kind of alluded to it, do you have to jump to some other modality? And that's where I think the crux of really understanding, and you brought it up, knowing what each of those parameters mean physiologically and how do you manipulate those based on what's going on the surgery side as well as the physiologic side.
Something I want to bring up, because you just made some great points there, areas. One, pay attention to that patient, pay attention to that surgery, know what's going on, right? Because we've got a lot of those factors. If you've done open heart cases, as well as I do, they start to lift that heart to kind of maneuver some things, manipulate. Then your preload changes dramatically.
Correct.
And you drop a pressure. If you treat it, then the next thing you know, once they've let that heart settle back down and that preload is returned back to normal, now you've got a very hypertensive patient, which is not very good.
And that takes a little bit of time, right?
It takes practice.
Yeah.
And you talked about it earlier, messing around with that superior mesenteric artery. Think about all the mediators that get released when you start talking about messing around with all that stuff that causes vasodilatation. It gets you hypotensive. And again, those factors matter. And it's knowing, for example, if you're using stroke volume variance, it's got to be a patient on pressure controlled type ventilation, right? You've got to have increases in thoracic pressure because of the physiology behind it. If you've got a patient that's spontaneously ventilating and you're just assisting them a little bit, it's not going to be, the number's not going to be accurate. So you really need to know how to use the monitor, and physiologically, what is it measuring? And physiologically, if things change, how's that going to affect your number? How's that going to affect what you see? Because that of what you're monitoring, whether it's the number, whether it's the trend, whatever it's going, has an impact on your treatment. So it all goes back to understanding the physiology behind it.
Are you a resident or CRNA looking to transition into independent practice? The AANA and Beyond the Mask are here to help you thrive as your own boss. Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Lean into the feeling of freedom and embrace the opportunity to be your own boss with the AANA as your partner on this exciting journey toward independence. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Visit aana.com/1099 to learn more and take the first step toward your new future. Remember, that's aana.com/1099 or click the link in the description of today's show. The 1099 CRNA Institute. thrive as your own boss.
And so that brings up another really important point as we start to see the emergence of more and more robotic surgery and the pneumoperitoneum. And how does that change the physiology? And how do we maneuver around some of those corners?
Well, I mean, doesn't everybody love a good robotic surgery? I mean, come on. But you're right. Anytime we start talking about putting pressure in the abdomen, pressure in the thoracic cavity, whether it is a thoracic case, right, and we're doing obviously doing a VATS or something like that, or whether we're doing an abdominal case and we got insufflation going on there, we're compressing the vena cava.
Right.
And that affects how much fluid is getting back to the right side of the heart. That affects the preload. We got to really think about that. The vessels, the inferior and the superior vena cava, are both vessels. So they're both very compliant. Therefore, with pressure, if they're not full, they're going to compress very easily, again, affecting the preload. So now that we're adding additional pressures in there using these kind of systems, fluid volume management becomes very key.
Absolutely. It brings up another point, and I speak a little bit on this topic in some venues, and some of the people that I have in the audience are people in like rural America where they don't have access to some of these technologies. And I'm like, well, you can still actually do this in your environment. It's indirect trending, whether you put an arterial line in and have arterial waveform, or even your pulse oximeter plasmograph. You can just change the sweep speed and start to look at the variation in respiratory variation. And it's a cruder approach, but it still works, and it's been proven in the ICU all the way back in the 1970s and 1980s. So some interesting caveats there. Well, let's get into some of the evidence, if you will, that really looks at impacting postoperative morbidity and length of stay of hospitalization and our high-risk surgical population and what that recovery looks like when we implement goal-directed fluid therapy into our practice.
So, when we start looking at high-risk populations, right, these are going to be those that we would anticipate to be high-risk populations, those with increased comorbidities, especially when you start looking at renal dysfunction, as you start looking at cardiac dysfunction, as you start looking at even pulmonary dysfunction, because we know if we continue to fluid load our patients, we know what that can do for a patient that gets fluid overloaded. When we start talking about oxygen transport, when we start looking at Fick's law and looking at that movement of oxygen molecules across these membranes, it impacts all of that. So we know that if they have increasing comorbidities, then we're going to have higher risk of complications associated with those patients. We also know in our larger surgeries, you just mentioned it. Let's take for an example, a simple, quote unquote, simple case that doesn't have a lot of fluid shifts associated with it, or a lot of tissue trauma and damage, or not a lot of blood loss associated with it. Not a big deal necessarily, right? However, we take those cases that we have the open triple A's, we've got the hepatectomies, we've got the pancreases, right? We've got the Whipples. We've got these major cases that we're doing where we're going to be there for an extended period of time. We're going to be losing some blood. We're going to have evaporation that's taking place. Then we're going to see that fluid therapy becomes very key in those aspects because, again, if we start to have decreased perfusion or this decreased volume that's circulating, right? We've got post-op nausea and vomiting. As simple as that. That's one thing. And the cost on a patient who was supposed to go home, but then has to be admitted for post-operative nausea and vomiting is thousands and thousands of dollars to the facility. Then we've got problems with bowel motility. And listen, we want that working. We all know that. We want that working. You've got anemia. You've got cardiovascular, respiratory complications. You've got coagulopathies that can exist. If we're under-resuscitating these patients. If we're over-resuscitating them, now we've got pulmonary edema or we've got pulmonary issues because of that. We've got increased problems with wound infection. We've got increased hospital length of stay, increased length of stay in the ICUs, increased risk of urinary tract infections. So we've got a lot of big problems here when we talk about if we under or over resuscitate these patients, But it's not just as simple as we used to think it was. Let's go 4-2-1. Let's go EBL. Let's go third spacing. Let's calculate all that out and let's just see what that's going to give. No, now it's more of, hey, let's get this right so that we optimize, especially those patients, as I mentioned, multiple comorbidities, larger surgeries.
Yeah.
We can do that. You mentioned doing a lot of bowel surgeries. Where did ERAS first come about?
Right.
And what
Absolutely.
was one of the major factors in ERAS, or the major things you talked about in ERAS, is fluid management.
That's right. Yeah. Yeah. You know, and that brings up is as far as the outcomes and how expensive this can get. You know, you've mentioned the thousands that it costs for postoperative nausea and vomiting. When we look at postoperative ileus, just to manage one of those ileuses costs between $10,250 to $11,000 per incident. And the incidence in the surgical population, these are studies of 400,000 patients, is like 15.3% incidence of postoperative ileus. You talk to a patient that ever has an ileus, they'll tell you that it's worse than the actual surgery itself, not to mention all the other complications, 30-day readmission rates, which is free care for the hospital. I mean, so you can start to see the cost starts to compound. Surgical site infections can be as high as $60,000 per incident. So really, and we actually have an impact on that, which is really important. And the reason why I think this topic is so important, making sure that people really understand the role that we actually play is quite crucial. You know, and we bring up, again, not to go back to colorectal and livers and stuff like that, those procedures do tend to be a little bit longer, and they, especially if the tumors are attached to vascular systems and there's a little bit of bleeding. Certainly in the practice that I'm in, you know, livers, pancreases, it is intentional fluid restriction until the resection is complete. Then you can give the fluid resuscitation. And sometimes these patients take a bit of a hit, not only just with, you know, sort of the impact of physiologic changes, but acute renal injury, which is one of those things that we want to be cautious about. And certainly, you know, one of the things in our practice, I follow lactic acid as a little bit religiously, gives me a good indicators like how far behind am I? You know, I had a case 2 weeks ago. It was a liver surgery. We did 7 resections, segments. We pringled 20 times. The lactate hit nearly 7, but I needed to be giving fluid restriction to optimize the surgical conditions. And you start getting into these gray zones that start to make you a little bit nervous. One of the keys there is I just make sure the surgeons are well aware, you know, where we're sitting and what the lab work is. And then, you know, I kind of jump to colloids, and I know that's another debate, colloid versus crystalloid. I do like to make sure that the vascular system is plump and it's not leaking out of the vascular system, like we see with
I love that debate.
Oh yeah, it's out there, and people, you know, the arguments of, well, albumin's too expensive and the risk of infection. We jump to albumin constantly. We do balance it with crystalloid, but I mean, it's, you know, well, let's actually get into a little bit of that. So,
yeah.
So
really, when you start looking at that, I mean, you're right on there, Gary. So it's got to be a mixture. You can't just do all crystalloid and you can't do all colloid.
Yeah.
So for a lot of my patients, especially, you know, I start talking about doing some of these orthopedic trauma cases that are coming in, and they have, you know, we're talking about 4 and 5 and 6 hour procedures sometimes. Is you've seen the studies, and we did this. I probably should say this, but we did this in anesthesia school, right? Put a 16 gauge on somebody and run a liter of crystalloid in.
Yeah.
You're gonna have that in about 15 minutes, right? If you open it wide up. But within the hour, 80% of that is leaked out of the vessel, and it's
absolutely
in the you know, it's outside of that vascular system. So it's actually doing you no good at all. And crystalloid actually helps when you start talking about that oncotic pressure associated with it, starts helping hold that in.
Right.
So I think there's a mixture. So I love using, you know, 500 cc's of albumin, 250 cc's of albumin, sometimes depending on the case and how quickly it is, to know that, hey, when I give this fluid, I've got something that 80% of that's going to remain inside the vessel. But not only is it going to remain inside the vessel, it's going to take that other solute, it's going to take that other solvent, right? It's going to take that other crystalloid and actually hold on to it in there itself too. So it's not just the albumin, it's what it's doing to the crystalloid by holding it in
Exactly.
itself when you start looking at oncotic pressure. And I think once we start understanding that, because I want to get to something you talked about, Gary, is you talked about kidney injuries, right?
Yeah.
And really one thing that's interesting fact, and I'm telling you, this changed my thought process several years ago, completely changed my thought process on things, right? I went to a presentation. It was on goal-directed fluid therapy, and they started talking about the HPI, right? The hypotension perfusion index, right? We started looking at that. And what they started talking about was, hey, MAP is not just the only thing we need to worry about.
Right.
Where we all used to say, hey, Gary's got a MAP of 55 here. I need to give him some phenylephrine, or I need to give him something to raise that MAP. MAP does not guarantee perfusion.
Right. Absolutely.
All MAP tells us is it just tells us there's a number high enough to promote perfusion, but it does not guarantee that if we don't have the right amount of fluid, the right constitution of fluid on board, along with that, then we're only doing nothing but artificially raising a number. And that's when it started to get back to me and start thinking about it too, is using more drugs like norepinephrine instead of just phenylephrine, because now I'm giving a little bit of a kick with it, which is helping.
Right.
We're getting fluid in, and we're getting that because healthy kidneys, even one hit to a healthy kidney, for if you read some of the reports, primes that system that if they continue to get some hits on it, eventually they will get acute kidney injury and potentially lead into failure.
That's right. Absolutely. Yeah, that's, I think, one of the foci right now in the debate is trying to couple, and I know, MPOG, which is one of the outcome data registries for anesthesia, and they're making a lot of predictions of acute kidney injury and not just limiting it now to mean arterial pressure and looking at other variables that we really need to be conscientious about. And to your point is, they used to give you a penalty if you used a colloid. And I asked the question from sort of the lead of that group, MPOG, and I said, why am I getting penalized for something that stays in the system and not do a blended mixture? And there was no good answer for that. And so that thinking and terminology and those definitions has certainly since changed. But yeah, really, really important things to really understand. So let's get into sort of what clinical guidelines are out there or consensus statements that are available for clinicians to kind of refer to and look at and sort of help guide their practice, if you will, with respect to goal-directed fluid therapy.
So a great question. And as we start looking at the research, we really need to look at recent research. You just mentioned that. And that's one thing that I really started hounding a lot of my students on and learners on. And I really love going to these meetings and having conversations with people because we get to have that current conversation. Is look at the current literature. And when I talk about current literature, we have to remember 10 years ago, literature was not as readily accessible. When you look at the technology now that we have, we can pull studies out easily left and right. And we need to make sure that we're looking at those studies. And not only that, do we know how to read the study? It's not just good enough to look at the conclusion and say, okay, here's what the conclusion says. And the conclusion says I should be giving albumin all of the time to all of my patients. Well, what was that study about? Let's just go back let's go back. I believe it was Dr. Bolt who did this about 15 years ago. You remember, and you know exactly where I'm going with that one, Gary, is, when we start looking at Hexspan and Hespan, it was the best thing ever invented. It was the right way to go. We should all utilize this. So when they started really analyzing his results, they found out all of them were made up.
That's right.
When you start looking at Hespan and Hexspan, we've got to have that as nurse anesthetists, as anesthesia providers, as wanting to take care of the patients in the best manner we can. We've got to have that critical eye to be able to analyze and evaluate these studies, these consensus papers. When we start looking at the reports, and you look at the blood component therapy, just for an example. I do a lot of presentations on blood component therapy. You go back and look at the latest consensus on that. That's 2006 when the latest consensus was put out. The first one was in 96. The last one was in 2006. And we haven't seen anything out since then.
20 years. That's crazy.
Yeah.
And we know a lot more about each of those components, which is, it's just kind of mind-boggling that there's nothing out there that's updated as of yet. So, and some of those back to Hakeem Bolt, I remember when the identification was revealed, and the last count I saw was, I think, 86 or 88 retractions that if you referred to his literature or his research, which was fabricated, it must be retracted certainly on PubMed, and you can see it. It's in little red writing at the bottom. They'll still bring up the article, but it'll say that it was retracted, and for obvious reasons. And that brings up informed consumer of research and understanding, teasing out whether it's good research or whether it's bad research. And, a little bit of a side topic, I was on an advisory panel for when Mallinckrodt took over Affirmative. And one of the studies, actually there's two of the studies that we were debating on the advisory panel was, is PO acetaminophen as effective as IV? And the studies were like 31 participants in each arm, where it's PO versus IV. I said, this might be a feasibility study perhaps, or a pilot, but I said, it's certainly not comprehensive. And I have images of pancreatic surgery. We're now at the point of the Roux-en-Y, or the gastric bypass. And so we're 6 to 8 hours in from when they took the PO tablet. I remember a day when the fellow was running the bowel, and he says, "Oh my God, there's a growth here." And so the surgeon says, "Well, let's open it, let's resect it." So they do an opening, and out pops a tablet. And I said, "What does it say?" And he says, it says Tylenol. And I said, I got to get a picture of this. So bioavailability of PO drugs in the perioperative setting, if you just look at fight or flight response, we're not digesting things or breaking things down in the perioperative setting because people, number one, are scared. And then you got surgical stress. And so, I think making sense of things and looking at literature, and certainly for us as anesthesia providers, anything that you can put in the IV to have ultimate maximum control, and that's inclusive of the fluids and types of fluids that we use, really important. I will say that there's a few guidelines and consensus documents out there. There's one called POCI, POCI, and that is a global comprehensive of providers in the perioperative setting, so surgeons, anesthesiologists, nurse anesthetists, etc. They have done a really good job of doing comprehensive sort of analysis of where and how much fluid. Obviously, it's case dependent. What kind of case are you doing? It's outpatient, inpatient, trauma, those types of things. But I found it. They did a really good job of looking at sort of global collaboratives of where we see fluid therapy, goal-directed fluid therapy, and where it needs to be. Certainly the AANA has some, they've leveraged some of that stuff from POCI and whatnot, but really important for, I think, our listeners to, if you're not familiar with or not really sure, to kind of look at some of those consensus documents. One of my colleagues, Dr. TJ Gann, sat in one of his lectures about goal-directed fluid therapy, and this was about a year ago, and he's like, sort of that fluid balance, if you will, by the end of your procedure should be somewhere between not too much more than positive 1 to 1.5 liter, whatever that combination of colloid crystalloid is. But that tends to be, we were 10 years ago, it was euvolemic or fluid contraction. We figured out that was not good because of AKI and whatnot. Now it's sort of swinging again a little bit to euvolemia is ideal, slightly plump, if you will, but not too plump. It's almost like the Three Little Bears. Yeah.
Yeah, so when you look at it, euvolemia is ideal, but I'd venture to say none of us reach euvolemic patients by the end of surgery. If so, we're all pretty much lying to ourselves.
Yeah.
But the thing is, fluid volume therapy is really important.
Yeah.
And I think that's something that we really, hopefully by the end of this podcast here, people will understand, right? Fluid volume therapy is important. And it's important for multiple reasons. And so we cannot any longer just say, all right, I'm going to sit back and I'm just going to give fluids and we're going to see how things work. or they're hypotensive, so I need to give more fluids.
Right.
We really need to start thinking about all of the physiology that goes along. And you mentioned it a little while ago. There's so many variabilities.
Yeah.
Surgery, patients.
Yeah.
Within the surgery in itself, what stage are you within the surgery in itself? Do you need to be hypovolemic here? Because, yeah, we're bleeding and we want to decrease blood loss. So we want to be a little hypovolemic, but I need to be ready that as soon as they stop the bleeding, as soon as we resect the liver or the portion of the liver, that we're ready to go. And what fluid do we want to use when we're ready to go? And that's something that's got to be considered. So I think when we start thinking about all of this, and again, looking at blood component therapy, I mean, I did a case a month or two ago where we got into a large amount of bleeding, and I mean a large amount of bleeding. And we were pumping fluids, I was pumping crystalloid and colloid in them. And then we got into, because we were having a little bit of blood loss to start off with, and I was trying to stay, again, looking at my numbers, trying to stay consistent, looking at my gases, looking at my base deficit, along with my gases, my lactate levels. So we're, looking at all of that. So all of a sudden, hey, we got to go to a massive transfusion protocol. And again, what fluids are we using? How much crystalloid are we giving during this? How much blood are we giving? How much FFP? So how much packed red blood cells versus FFP versus cryo? So this, when we start thinking about goal-directed fluid therapy, and I think a lot of people really start thinking, okay, this is for my big abdominal cases.
Right.
This is for my GI cases, my colon resections.
Sure.
This goes all the way down to just ERAS protocols and lap choles.
Yep.
To really all the way up to our traumas and our open AAAs and our massive transfusion protocol type scenarios.
Yeah. And that landscape is very diverse, if you will, and really important to, as you point out, to look at that clinical scenario and where does goal-directed fluid therapy not only fit in, but what is your approach going to be in managing that fluid therapy, if you will, based on patient population, based on the surgical intervention, and then what the expectations are. Are they going to go home that day? Certainly we don't want to over-resuscitate somebody and then all of a sudden they're back, a week later, and, pulmonary edema after deresuscitation happens with all the fluid shifts. And that actually brings up, I do also a lot of HIPEC cases. It's one of the ones that makes me feel uncomfortable with fluid therapy, because it's not uncommon to pour fluids into these patients, because when they do the hyperperfusion with the chemotherapy, the amount of fluid shifts, if you will, are pretty astronomical. But one of the things that we do, number one, is they do get plumped up, and it's liters of fluids. We try not to transfuse, and if we can get to a hemoglobin of 9 or maintain it between 9 and 9.5, it keeps them anticoagulated enough, but they maintain oxygen carrying capacity. We start bridging down below 9, and we start looking at other parameters to make sure that they're able to compensate and manage. And to your point, massive transfusion protocols. When do you push the button to say, fluid's not enough? I need oxygen carrying capacity, which fluid is not going to, it'll help deliver, but you want oxygen carrying capacity. And the only thing that does that is red blood cells. So really interesting. So let me ask you, if there were 5 major things that a clinician should walk away from this lecture, what would those 5 things be to help in their clinical practice?
Oh man, great question, because there really ought to be take-home points from every presentation, right? That we really got to look at those goals and objectives. And I mean, one is, we really need to understand what goal-directed fluid therapy is about.
Yeah.
So the really to understand that, we need to study what patient populations are these optimal for. Right. So that's one thing that we've got to look at. And yes, it's optimal for everybody, to be honest with you. Now, yes, we probably will use it more in those patients with higher surgical level procedures and so forth, but it's great for everybody. Second, not all fluid is created the same. Mm-hmm. And therefore, we need to be thinking about what fluid do we want to give. The third is understanding physiology behind cardiac output. and understanding physiology behind systemic vascular resistance. Once we start understanding the physiology behind all of that, then we will see actually how the first two are important for treating blood pressures, right, and maintaining perfusion to everything. Fourth, know the monitors. Whether it is pulling research on them, whether it is looking at the manuals that they have, whether it's watching videos online, going to presentations at our meetings, wherever it may be, know the monitors. They all vary. So know them so that you understand what the numbers mean. And are you actually using the monitor in the right parameters to get the optimal numbers? Those are the four biggest. And the fifth, I'd say, is, stay on top of your education and your research. So make sure you're looking at the research, make sure you're analyzing it, and make sure you're staying educated on everything that's going on within the procedures in itself and all the new techniques that are coming about. I remember you talking about Hypotension. I remember when we started doing our first Hypotension procedures at our facility, we had to understand. We just started doing liver transplants a couple of years ago.
Wow.
We really had to dive into those literatures to understand what are these surgeries about and how is it going to affect goal-directed fluid therapy.
Yeah, that's a big one, because I think every surgery is not created equal for our patients and how we manage them. And so certainly that's a key point there. Well, Richard, I want to thank you for joining us today on our podcast. This has been extremely insightful, and hopefully our clinicians out there find it very, very helpful information. And hopefully we've helped them sort of lead them to reinforcing the importance of looking at the literature and staying on top of things, because even fluid therapy changes from year to year, and whether consensus documents get updated, as we've pointed out, and some of them can be 20 years old, and so that's just too long, and we need to stay at the front. So with that, I want to thank our audience for listening to this Anesthesia Alchemy podcast today on goal-directed fluid therapy. Certainly jump on over to the website, give us a like, a dislike, give us a comment. What would you like to see in future podcasts? So with that, I want to thank you for joining us, and we'll see you on the next episode of Anesthesia Alchemy, Lynn and Garry Unplugged. Thank you.